Friends, I understand, and I appreciate you taking your time and spending with me for the next hour or so. All right. So my name is Christopher. You can call me Chris later. And today I'm talking about cementation. But before that, I think you are very familiar with Singapore, the city which I come from, and the many things that have happened and over time. So I'm grateful to be here. And I'd like to say that I'm also from the university, the National University of Singapore. So, from the faculty, we would like to thank you for inviting me as well. Okay, so without wasting more time, I just want to dive into cementation because that is something which is very crucial when we are restoring teeth as well. So why cementation matters is because with the right cement and the protocols, you end up with long-lasting restorations like this. Okay, all of us who practice restorative dentistry would obviously want a restoration like this. Okay, not only on the first day when they get their restoration, but as well as for the next 5, 10 years, or hopefully for the rest of their life. Okay, because nobody wants to do a restoration. Okay, so we are aiming for this, but at the same time, we are always worried that you will end up something like this. Okay, cases like this where patients come in with maybe a bridge that has broken off, and sorry, right, broken off, and we are very concerned about why this happens. And from here, it could be because of recurrent caries, because the cementation procedure was not done correctly or not understood well. So this is where hopefully I will give you some ideas in how to manage these type of cases in the future. All right, because you know these type of small errors can actually lead to very expensive redos. Okay, as a clinician. Okay. So I will go and run through a brief history of dental cements in general. Okay, where we started from, and where we are right now. Okay, and obviously there will be some science in why certain cements work, and obviously all of us want to go back with tips on how to start cementing our restorations tomorrow. Okay, if not tomorrow, then on Monday. Okay, right. So it all started back in the 80s, the late 80s, okay, way before we were born, okay, 1800s or so, where the first cements were, these are the classic zinc phosphate cements. We still use zinc phosphate now. I think in the faculty, we do have zinc phosphates, which we use once in a while, okay. The thing with zinc phosphates is that we know that it is acidic, it's actually so water soluble, that's why cement or crowns get dislodged. There's no chemical bond to the tooth itself, okay? And that's the main concern with cements. So early times when dentistry started, it was all using zinc phosphates, 1800s. And then things started to change. Things started to change in the 1960s. Okay? In the 1960s, with research into cements, we started looking at things like a zinc polycarboxylate, which does have a bit of adhesion to tooth structure, which is what we want. There's some strength, but unfortunately, it is a bit more viscous, very thick. It still did not bond to tooth as well. Okay, but these are the early days, and we still have things like zinc polycarboxylate in our practice right now. A tip is that zinc polycarboxylate is a very useful cement which I use for temporary cements. If you have a temporary crown and the crown height is very short, the zinc polycarboxylate is a very good temporary cement to retain that provisional until the patient comes back before we fit on the final crown. Okay, so this is what I use for, especially typical cases with the lower second molar, sevens. Sometimes they're very short. Okay, so this is a tip which I normally do. Okay, that's adhesive. But then in the 1970s, things started to get a bit more interesting because of glass ionomer cements. Okay? Glass ionomer cements came out in the 1970s. There was chemical bond, and then of course we were very excited because of the fluoride release, right? You all know that fluoride does wonders, right? It's kerogenic, and that's what we want. Okay. Unfortunately, it's also moisture sensitive. Okay, so the traditional glass ionomer cements are actually all powder liquid mixed. There's an acid-base reaction to it. Then it got even more interesting because in the 1980s, that's where they thought, okay, glass ionomer cements have the advantage of fluoride and the certain bond to the tooth structure. Okay, why can't we make it a bit stronger? So they added resin to it. Okay, so when they added resin to it, you could actually light cure it. Okay, it changed the properties of the cements a lot. Okay, it became dual setting. Okay, meaning you can use your light cure to set, or by not curing, not using a light, it will set by itself. Okay, useful for cementing crowns under metal crowns because you can't get light underneath it. Okay, so there's a setting reaction. Acid base, improves strength, and so on. Okay, and then we move on to where we are right now. Okay, which is that adhesive revolution, if we call it. 1990s until now. Okay, that's where you have the understanding of the hybrid layer. Okay, this complex interface of your dentine, which is not only the collagen fibers as well, but the matrix as well, and how to integrate that matrix into interface that allows bonding. Okay, that's where it came in. Adhesive revolution. Resin cements, it became a micro-mechanical as well as a chemical bond. So the bond became very strong. Okay, its strength is there, low solubility. So because our mouth is full of saliva, okay, we worry about cements leaking. But in the past, zinc phosphate cements, they leak. That's why restorations dislodge or break off. Unfortunately, because of all this, it's more technique sensitive. Meaning when we are using resin cements, we are very careful to make sure that the surface is not contaminated with saliva, with blood, and so on. Okay? Right. So this is just a quick example of this little hybrid layer we always talk about. Okay? So this is where we are right now. This adhesive revolution using resin cements. Okay? We are always faced with many restorations. It's very complicated. Okay? In our practice, we are going to cement things like your crowns. Even within crowns, we have different type of crowns. Okay, your full ceramic crowns, you have zirconia crowns, porcelain fused metal crowns, and not only that, you also have inlays, onlays, and so on. So there are so many things that we need to cement. Okay, so it's actually very complicated. Even at the bottom here, you can see the cast posts and cores, okay, which we also do very often, acid etch bridges, and so on. Okay, so we are faced with a complex, or rather, we are faced with many choices. Okay, so there are many different surfaces. Okay, so we sweat by thinking of the many different surfaces. Not only in terms of restorative material, these are all the materials that you're going to cement. You have your lithium disilicates, okay, your glass ceramics, your composites, your metal alloys, and I mentioned earlier posts as well, fiber posts, metal posts, and so on. Okay? Then you have another layer to think about, which is your cement. Okay? You got the material, you got cement, and eventually you also have your tooth. So there are many combinations, okay, what to use. Okay? So these are, even in tooth itself, you have enamel, you have dentine, and then if you have your post and core inside, you have post and core, and now with implant dentistry, you have titanium as well. So what to use? These are the things that we will always be faced with, and we want to try to simplify things. I am always of the opinion dentistry should be as simple as possible. Okay? Keep things as simple as possible. Okay. So the choice of cements can range from and the one end your zinc phosphate, polycarboxylate, glass ionomers, all the way to resin modified. So in terms of this, it is different reactions. Okay, the ones that you see on the pink side, these are acid-base reactions. Okay, in water. When you move on to this side, the middle portion, which is your resin modified glass ionomer, is actually a hybrid of the two. We try to link the two together. So you have polymerization or your metacolate monomers. Okay, that's where the chemistry comes in. Then you have things like it's self-curing, it cures by itself, you don't have to use the light, until the when, and then in the middle you have a dual cure, right? And finally there's purely light cure. Okay? You have how it is cemented or attached to the tooth is based on either macro-mechanical retention. Okay, this would mean roughness of the surface of the tooth. Okay, after you prepare the tooth, it's a bit rough, so it attaches to it. Then you have some ionic bond, okay, which is a weak bond, okay, typical for glass ionomer cements. Then you have your micro-mechanical chemical bond to the tooth and functional units because of the chemistry of the cements. And also you have this ability to bond using adhesive, using primers and so on, okay, to improve the bond. Okay, so if you look at this, it's very complicated. There are many options you have. Okay, but if you look at it also from a bird's eye point of view, you can see that the ones on your left side would be the traditional, more the traditional cements. Okay, your zinc phosphates, glass ionomer. It's easy to use, easy to mix, easy to fit. But when it moves on to the right side, where you need the bond, chemical bond, that's where it gets a bit more technique sensitive. Okay? So knowing this in mind, then we can decide, okay, these are the cements, these are your tools which you have to cement your restorations. What can you do with it? Okay. So cement properties as well, something that we must all be aware of. Okay, this goes back to dental school days. Okay, when we are dental students, what do we need to know? And it's also something which I teach my dental students. Okay, zinc phosphate, all the way. It's a spectrum. Okay, when you look at this spectrum, you think of bond strength, mechanical strength, solubility, resistance, aesthetics. It goes from low, from the zinc phosphate, then all the way to very high for the adhesive. So it's on the range. Okay. But obviously, if another way we look at it, we also look at things like how easy it is to use, okay, the economics of it, how much it costs. Okay. We are always concerned with cost as well. Alright? So cost is a real thing. Traditional cements are usually cheaper. The new resin cements, I'm sure you have seen at the exhibitors, all cost a bit more. Okay, so we need to balance on this. So these are some of the considerations that we have. Okay, so this is just a bird's eye picture of all the cements we have. Obviously, within the cements, there will be different brands that fit into it. Okay, right. So the rationale for using cements. When do you use what type of cements? Okay, I base it on this picture here, the one you see on the left side. Okay, resistance and retention form. Okay, in the diagram on the top, okay, is low resistance, low retention. You see where the prep is just a little bulge, round thing. When you think about it, it doesn't retain the crown, it can drop off. The bottom one is a crown preparation. You got a tall tooth height, very good. Okay, so these are the things which I look at, and at the same time we also look at material strength. Ideally, you have a strong material and you have a good preparation, then honestly what I would say is that it doesn't matter what cement you use, because the resistance and retention form from your prep will hold the crown in place. You just need a cement to hold it there. Okay? But when you are faced with poor resistance and retention form, right, and the material is not so strong, then you need other cements to help you. So the other category of cements, resin cements, usually will cover all that. Okay? But I'm saying that even if your practice is just only resin cements, it will still work. Okay? But I would normally think about it in terms of resistance, retention form, and the material strength. The bottom part shows you the material strength. Strong materials that you will have would be your porcelain fused to metal crowns, full metal crowns, zirconia, those are very, very strong. Okay, the weaker materials, or not so strong, even though they are strong, would be your glass ceramics, your lithium disilicates, EMAX, and so on. So this is material. Okay, so this will have bearing in terms of which cement you will try to reuse. Okay. Recommended preparation for conventional crowns. If you look at this is a normal crown prep for molar, based on the article by Goodacre back in the 2000s. It hasn't changed very much. If you've got a height of about 4 millimeters for molar, height of the tooth, the prep, you're actually quite good. But not only the prep, the height. The other thing that you need to consider is the taper. How much you prep, okay? Ideally, the convergence angle, which is the taper of the tooth, about 10 to 20, you are good. Okay? When you do that, you're kind of in a very safe zone for the molar. Okay? Molar is one thing, anterior teeth is probably a bit slightly different, but similar concepts. Okay? But in reality, when we look at real-world studies, we find that when you actually prepare teeth, very seldom do you have the convergence angle of 10 to 20. Most of the time, people over-prepare the teeth a bit more, 26% or more, or even worse. Some of my dental students prepare too much. Okay? Then what it means is the crown may not be so retentive, so very few will prepare teeth that are of adequate retention, resistance and retention for. Okay? So then cement play a part if the preparation may not be so ideal, so good. So question is always asked, to bond or not to bond? That is the question. Okay? Meaning, if you have a case that requires all these that you see in front of you, alright, you like fluoride, you want to be able to retrieve it, maximize intraoral use, economic, expensive, then you can consider conventional cements, zinc phosphate, your glass ornament cements. Okay? But the material has to be strong. Okay? And your prep must be retentive. Okay? But on the other side, if the preparation compromised tooth itself is not retentive, then materials are not so strong, then you will need to use things like your resin cement. Okay? So the prerequisite is you need to isolate. That means because it's a more complicated procedure, right? You need to be able to control the moisture. Okay? So these are some of the considerations that you need to, which I will consider. So, dental cement selection guide. Okay? So these are the indications, and what it means with the indications is that this is the material. Okay? Zirconia, glass ceramics, resin base. Okay? Zirconia, we all know. Zirconia, I normally will equate if you have a zirconia crown with a metal crown, same. Right, the same materials because they have a metal oxide layer. Okay? Glass ceramics will be the common ones that you are very familiar with, EMAX, lithium disilicate or something like that. Resin-based ones will be your composite inlays and so on. Okay? Right. So knowing this matrix will show you corn is actually conventional cement. Okay, your conventional cements which I mentioned, which you're very familiar. SAR stands for self-adhesive cements. Okay, commonly ones that are available like your like Reliance, okay, something like that. And then when you're talking about adhesive cements, then you go to the full range where you actually use the glue bonding agents. Okay, these are something to consider. But just a note of caution when it comes to the veneer section. I typically would want to use a purely light cured resin cement. Okay, the reason why it is that because of when it comes to dual cure, there are certain chemicals in dual cure, the amines that are there, that tend to over some time after you cement, may degrade and change the color of your very nice white veneer which your patient has. The last thing I want is for the veneers which I put into my patient's mouth to change color because of the cement. Okay, so I purely use the light cure. Okay, but day to day, we are always I'm always concerned about whether to use a conventional cement or a self-adhesive or adhesive cement. Okay? So which materials are suitable for conventional cement? Using conventional cement like zinc phosphate, resin modified GICs. It can be conventionally cemented if you have these type of restorations. Okay? As I said, metal restorations, zirconia restorations, and even lithium disilicate. Okay? Some people think lithium disilicate restorations always have to use resin cement. Okay? Yes and no, depending on the thickness of the lithium disilicate. Because sometimes, because of the strength of lithium disilicate, it's actually more than 1 millimeter thick, your preparations allow you to. I would normally just use a simple conventional cement like a resin modified GIC. It works quite well. Okay? When can you not? These are the things, any of your feldspathic, your traditional feldspathic